So what we've done is gone through and removed all of the lamina, we'll talk about those tomorrow, to reveal the spinal cord. The spinal cord starts at the big hole in the back of the skull, the base of the skull, called the foramen magnum. Grossly, that's where the spinal cord starts. When you get into the neuroanatomy, there's a little bit more of a ambiguous transition, but generally, it's the foramen magnum. The spinal cord in the adult ends around the L1, L2 vertebral level. You got 7 cervical vertebrae, we'll talk about those tomorrow, 12 thoracic vertebrae, and 5 lumbar vertebrae. So the spinal cord ends about, we'll say L2, vertebral level. You have to make sure that you distinguish between, are you talking about the L2 spinal cord level or the L2 vertebral level? Because if you take a gunshot, if you take a bullet to the L4 vertebral level, you won't hit the spinal cord. Because the spinal cord stops up here. But you still have to get innervation all the way down. These nerve rootlets have to come down off the end of the spinal cord to go out at each level. When you dissect it out tomorrow, it's going to look like a horse's tail. That's the cauda equina. They're nerve roots. They're the dorsal and ventral roots. There's no spinal cord down there. So if I ask you, this guy was shot in the L2 spinal cord level, what vertebra was hit? Well, if the spinal cord ends at L2, that would be the coccygeal. Let's say coccygeal 1, sacral 54321, L5432. The vertebra that was hit was T10, the 10th thoracic, because the L2 spinal cord is up here. The L2 vertebra is down here. Y'all all went to Colorado over the weekend, didn't you? You got loaded up. So, the L2, all right, keep this in mind. The spinal cord, if we're talking about the spinal nerve, I said you have 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, 1 coccyx. Right? The spinal cord ends right there. But you still have all these rootlets that are forming the cauda equina. So if you got shot in the L4 vertebra, that was down here. It didn't touch the spinal cord, it hit the cauda equina. But if I said he was shot in the L4, or he has a lesion in the L4 spinal cord, you have to count up from L2 vertebra. The spinal cord stops at the L2 vertebra. That stoppage of the spinal cord would be the coccygeal 1. So you have to count backwards until you get to L2, and that's going to be about at T10 vertebra. Does that make any more sense? Yeah, I think there's a better picture. Hang on to yourself until we get there. Okay? Now, what's that?
I don't understand why they don't match up so that it's a...
But because when you were a little bitty embryo, your spinal cord was the same length as your vertebra. So all of the spinal nerves came out straight. But as you grew in utero and then after birth, your spine grew faster than your spinal cord that doesn't grow very much at all. So the spinal cord essentially stays here and your vertebra group downward. So there's no spinal cord down here. And that's why. So the nerve roots, but the nerve roots still have to come out. So they have to come out and go down like that.
So all of the levels are present in the spinal cord, they're just compressed up higher, and then they send the roots down and come out through.
Right, so if we come up here to the cervical region, you see those are coming out straight. But then the further you go down the spinal cord, they start doing like that because they're having to reach and go out lower and lower foramina. Okay? There's a syndrome called cauda equina syndrome where pressure is put on the cauda equina, either from a tumor or from trauma. If you compress the cauda equina, understand that these nerve roots down here, the sacral and coccygeal nerve roots, they're going to your lowest levels of your segmentation, which is down around your, it's called the saddle region, whatever's in contact with the saddle, your junk, right, your perineum. Saddle numbness is a symptom of cauda equina syndrome. This has to be detected, it has to be diagnosed, it has to be surgically corrected. You got to get the pressure off the cauda equina, or you'll wind up with urinary, always, and sometimes fecal incontinence. So anytime a person comes into the clinic with an acute back injury or chronic back pain, I always ask them, do you have trouble peeing, and do you have numbness down here in your private parts? And you document that. You don't ever want to miss cauda equina syndrome.
Is that urgent? Is there like a timeline?
Yeah, you have hours to get it. That's an immediate, that's a medical emergency. You find a neurosurgeon and get them there immediately. Now, I keep talking about these levels. So the level of innervation of the skin is called the dermatome. The dermatome and the underlying muscle, which is called the myotome, represents a segment. Yep, right and left, dermatomes or myotomes. And this goes from the first cervical all the way down to the coccyx. And it's like this. C2 innervates the back of the head, back of the scalp, C2. This is one of those cases where, we talked about the 4 functional components, where one of the nerves doesn't have them all. C1, you don't see C1 up there. C1 is a motor nerve only. It does not have somatic afferents. It only has somatic efferents, and visceral efferents and visceral efferents. There's no somatic afferents in C1. So if I'm talking about dermatomes, the sensory chart, there's no C1. C2 takes the back of the head. C4 is the top of the shoulder right here. T4, T5 is the nipple line. T10 is the belly button. Coccygeal, or low sacral, is your under anus. So when you have a nerve injury, or if somebody comes in and complaining of pain radiating down the lateral part of their leg, or they have foot drop, where their foot they can't raise their foot up. You are segmentally innervated. You don't need an MRI to find the problem a lot of the times. If you understand the dermatomes and myotomes, then you're headed in the right direction. Now, I don't want you to memorize all these dermatomes here. That you're not going to be tested on the dermatomes. But you need to appreciate how you're laid out, segmentally like a worm. You know, deep tendon reflexes. Deep tendon reflexes. What are deep tendon reflexes? Is that not proprioception? You know, when you do that right there, I know where my knee is in space. Why do you have deep tendon reflexes? Deep tendon reflexes. You know, I talked about the hand on the hot plate, you pull it back. It's the same thing with deep tendon reflexes. If I'm walking along here and I think that the step is there and I miss the step and I do like that, I catch myself. I just did the same thing as a deep tendon reflex. Without having to memorize a whole bunch of stuff, I can tell you that the Achilles deep tendon reflex is S1, S2. You don't need to write this down because you're going to know it later on. The Achilles reflex is S1, S2. The patellar reflex is L3, L4. The biceps reflex is C5, C6. The triceps reflex is C7, C8. 1, 2, 3, 4, 5, 6, 7, 8. Boom, you got it. Okay? So when you do your physical exam and you're testing these deep tendon reflexes, which is part of this, you have to understand what you're testing. The anatomy of the spinal cord. We talked about gray matter being on the inside, the white matter being on the outside. We know about the dorsal horn, ventral horn, lateral. We know about the ventral fissure. We know about the dorsal septum. You're getting to be experts here. Getting to be experts here. If you take this, understand that the gray matter is a column of cells. It's not just a segment here on top of a segment there. It's a column of cells. And as these cells, as this column goes up and down, the different rootlets coalesce and come out to form the ventral or the dorsal roots. Okay? On that earlier illustration that you saw in the 9-page document, it showed the dorsal root ganglion looking like that. That's not really the way it works. That's more like what it looks like right there. If you could section this histologically, you would see that it's separate. But when we dissect it out tomorrow, it's going to look like the dorsal root ganglion is right there at the spinal nerve. So, which is what it shows here. It looks like they all come together at the dorsal root ganglion. That's not really correct. If you could slice them and look at them microscopically, there's a line between the two. And this slide right here, it just goes to show you that it takes the spinal cord and sticks it in the vertebral canal. The hole in one vertebra is called the vertebral foramen. If you stack a bunch of vertebrae on top of each other, it makes a canal. So you have the spinal cord sitting in here. The dura mater, I'll talk about here in just a minute, is surrounded by a venous plexus. There are specific arteries that go to the spinal cord, but the venous drainage from the spinal cord is from an internal and an external plexus that you see here. The only reason I put this up here is because that plexus, that venous plexus, a lot of it communicates with the vertebral body. And from there, it gets into the peripheral or the central venous circulation. By being able to circulate with the vertebral bodies, if you have cancer that's spreading, it spreads by this route. That's why you get bone cancer of the vertebral column through primarily the venous circulation. prostate, breast, and kidney, notorious for going to the bone of the vertebral column. As well as others. But. Okay, so if you look at this card, okay, so here's kind of, maybe we'll help you out a little bit. The spinal cord stops here. And as it tapers down to a point, it looks like an upside down cone. That's why it's called the conus medullaris. Off of the end of that cone is a structure called the filum terminale. It anchors the spinal cord to the coccyx. It anchors the spinal cord up and down. And you can see how up here, those spinal nerves come off perpendicular to the cord, but then they start elongating almost parallel to the cord as you get down to the lower dermatomes. The cord also is not continuous, it is not consistent all the way down. There are two areas of enlargement. There's a cervical and a lumbar enlargement, and the reason they're enlarged there is because there are so many cell bodies, alpha motor neurons, that are going to the arms and to the legs. Arms for the cervical, lumbar enlargement for the legs. You can see them right here, how big that ventral horn is in L4 and up here in C4. If you look at these histologically, you can, in a cross-section, you can see that the size of the dorsal horn or the ventral horn varies according to the segment. And I'm not going to ask you to identify a segment of cord. I just want you to know, though, that where you have these enlargements, you're going to have a large ventral horn. Right there in the low thoracic, remember T1 to L2 is the sympathetic. That's where the IML is. You can see the lateral horn right there. There's the lateral horn. If that's low thoracic, there's the lateral horn. Now the cord has 3 layers of protective tissue around it. You know what they are, the pia, the arachnoids, and the dura. The outermost layer is the dura. Inside of that is the is the arachnoid. Now in the spinal cord, tomorrow, when I open up the dura, and I open it up, you're going to be looking at the outer surface of the arachnoid. It doesn't attach to the dura. In fact, the dura doesn't attach to the overlying bone of the canal. Then we'll cut open the arachnoid to reveal the pia. The pia is the outermost covering of the spinal cord. When I open up the arachnoid, you're going to see these little tiny filaments that run from the arachnoid down to the spinal cord. They look like little spider web things. That's why it's called the arachnoid. In the subarachnoid space is where you will find the cerebrospinal fluid. Now, the pia has a couple of unique features. The filum terminale that I mentioned earlier is pia. It anchors the spinal cord north and south. Also coming off of there will be these little things right here called denticulate ligaments. These are little pieces of pia that come up, pierce the dura, and pierce the arachnoid and anchor to the dura. They stabilize the cord laterally. So denticulate ligaments and the filum terminale are structures made from pia. They're non-neuronal. You'll see those tomorrow. By the way, if you want to block somebody during delivery of a baby so they can't feel anything, you can do an epidural. An epidural is, they come in through here and inject the lidocaine epidurally, above the dura. And it diffuses through the meninges to get to the cord. Epidural. Versus a spinal anesthesia is you inject the anesthetic into the subarachnoid space. When you were a little bit baby, that's what your spine looked like. This is the primary curvature like this. You were like that. And as you became upright and started walking in a bipedal manner, you maintained two primary curvatures in the thorax and in the sacrum. But you developed two secondary curvatures in the cervical region and in the lumbar region. The primary curvatures are called kyphosis, K-Y-P-H-O-sis, kyphosis. The secondary curvatures are called lordosis, L-O-R-D-O-S-I-S. Because the spinal cord stops at L2 in the adult, and you've got this big thing down here where there's nothing but cauda equina, if you want to obtain cerebrospinal fluid, that's where you want to stick it. This is called the lumbar cistern.
Lumbar.
Cistern. C-I-S-T-ern. Cistern. You get figured out pretty quick. I can't spell worth crap, so I know it starts out as C-I-S-T. In a newborn, if you need to get cerebrospinal fluid, where do you think you stick the needle? You don't stick it there, because the spinal cord's still down there. Where you go is actually through the back of the skull, right through the foramen magnum, into a cistern back there in a newborn. You can do a lumbar puncture in a newborn, but it's risky. And that's what the next illustration shows you. What's going on here is we're taking that needle and sticking it between L3 and L4, or L4 and L5, into the lumbar cistern. Because there's no spinal cord there, you've got nothing but these cauda equina, and I stick the needle in there, they'll move out of the way. If you stick it up here, the cord has no place to go. Let me get you down here, let me show you. So how do you know if you'll lie here on your right side facing this way? So what you do with a lumbar puncture here, you can do it sitting up. And if you're pregnant, sitting up is the easiest way to do it. The mama. But most of the time, you're going to do it with them lying on their side. Now, what you do is you get a big nurse, and this 4-year-old with a high fever, stiff neck. You got to get, and the CT was normal. You got to get that spinal tap done, or lumbar puncture. What you do is you get that big nurse to get under the knees and get up here and scrunch them like this and hold them still. You take your hand, there's the top of her iliac crest right there. And if you draw a line straight down from there, right there, that open, come down here. Right there, feel right there. You can feel her spinous process up there, and one below it, right there in that gap, that's where the needle goes. That's between L4 and L5, in line with the top of your iliac crest. Okay? So what you do is you pull your finger down, feel that gap, take your fingernail and stick it into their skin to make a mark. And then you clean it, anesthetize it, and stick it. You'll do this in December on each other. Not really, not Okay, so let me tell you what we're going to do today and later. Today, all we're going to do is you're going to take the cadaver, put it in a prone position, face down. We're going to remove the skin of the back, and there's an illustration in the dissector how, the lines you want to do. You want to get down to the muscle, to the deep fascia. So some of the cadavers, the lumbar fat down here is going to be a couple of inches thick. So don't go through the deep fascia. Try to stay superficial to it. You want to cut, remove the skin overlying the cervical muscles, the top of the shoulder, down to the top of the brachium here, and all the way down to here. Don't get into the abdominal muscles, but just remove the skin of the back. Tomorrow, we'll define the muscles, we'll do the spinal cord. Today, it's just an introductory, remove the skin of the back. Okay? And so let's just head on over there.